Hello everyone and welcome to our module on personality disorders. Let's start by talking about personality traits. A personality trait is a fixed pattern of behavior. It's a way that people socialize and interact with their environment. And a personality trait does not cause significant distress or impaired function. And there are lots of personality traits. You may have some of these yourself, or you may know others who have them. Positive traits are things like being kind or confident. Negative traits are being things like lazy or rude. And these are parts of what make up our personality, but they don't cause significant distress or impaired function. That's what makes them traits and not disorders. And often a person is aware of their own personality traits. We can often describe to another person our own personality traits and tendencies in terms of kindness or laziness or things like that. Personality disorders are also fixed patterns of behavior. They are also ways of interacting with the environment and socializing. But in contrast to traits, personality disorders cause distress or impaired function. And also in contrast to personality traits, a person is often unaware if they have a personality disorder. And in this video, we're going to go through all the personality disorders. They are all treated with psychotherapy. They are famous for being difficult to treat. They're called enduring because it's hard to make them go away. And they often stress or strain the doctor-patient relationship. You will meet patients who have these personality disorders, and the personality disorder can get in the way of treating the patient. Personality disorders are traditionally divided into three clusters: Cluster A, Cluster B, and Cluster C. The Cluster A disorders are called the weird disorders. There are three of these, which we'll go through in this video. And in general, the Cluster A disorders are similar to one another because patients with these problems display odd and eccentric behavior. Cluster B are the wild disorders. There are four of these, and they are called wild because these patients in general display dramatic or erratic behavior. And then lastly, there are three Cluster C disorders. They are known as the wacky disorders, and that's because these patients tend to display anxious and fearful behavior. We'll start with paranoid personality disorder. Patients who have this disorder, as the name implies, have a distrust of others, even family and friends. So they often behave in a guarded manner, careful of what they say and do. They're suspicious of others, and they struggle to build close relationships because they don't trust other people. And in the video on defense mechanisms, I talk about projection, and that is a classic ego defense employed by patients with paranoid personality disorder. So when a patient is projecting, they will attribute unacceptable thoughts of their own to others. And the way this usually manifests in patients with paranoid personality disorder is they often accuse others of being suspicious, even though in reality they are the suspicious one themselves. Patients with schizoid personality disorder choose social isolation. They are more comfortable being alone. And I've bolded the word choose because this is very important. If a patient wants to socialize but can't because of anxiety or fear, then that's not schizoid personality disorder. Patients with schizoid personality disorder prefer social isolation and select to do that on their own. In general, these patients do not enjoy close relationships. They have little or no interest in sexual experiences, and they have very few pleasure activities and hobbies. They tend to not have many close friends, and when you interact with them, they tend to be very detached and have a flat affect. Patients with schizotypal personality disorder have a fear of social interactions, and they have few close friends. So in contrast to schizoid, these patients are afraid of social interacting, and they are isolating themselves out of fear, not out of choice. The classic feature of this personality disorder, and the one that you can usually use to recognize it in a board question, is that these patients have odd beliefs or magical thinking. They are often superstitious. They can tell you they believe in telepathy or in a sixth sense, and this is always the hallmark of this personality disorder. They can also tell you about ideas of reference, so they will believe that events and happenings are somehow related to them. For example, something that appeared on the news was on the news because it was trying to send them a message. That's an idea of reference. Now, some of these things may sound like psychosis, but patients with schizotypal personality disorder are open to challenges to their beliefs. And this is what distinguishes them from patients with psychotic disorder. So you can talk to them and get them to reconsider their superstitions or their magical thinking. And this is something you can't do in patients who have delusions from schizophrenia. Also, unlike schizophrenia and psychotic disorders, there are no hallucinations and no cognitive impairment. Now we'll move on to the Cluster B disorders, and the first one is antisocial personality disorder. This is a common personality disorder in men, and it's defined by a disregard for the rights of others. So these patients often break the law. They are very impulsive and they lack remorse for their actions. And people with this form of personality disorder often end up in jail because of their behavior. If a child, meaning someone under 18, has evidence of this personality disorder, we call that conduct disorder. And children who have conduct disorder frequently grow up to become adults with antisocial personality disorder. A quarter of girls and 40% of boys who have conduct disorder will eventually meet criteria for antisocial personality disorder when they become adults. And so two of the important criteria that you must meet to have antisocial personality disorder are you have to be at least 18 years of age. If you're younger than that, you have conduct disorder, not antisocial personality disorder. And also you must have evidence of conduct disorder before the age of 15. So people don't behave normally throughout childhood and then suddenly develop antisocial personality disorder in adulthood. They always show evidence of conduct disorder at a young age, and then later in life when they're adults, they meet criteria for antisocial personality disorder. The second cluster B disorder is borderline personality disorder. This is more common in women, and it's defined by unstable personal relationships. So the classic feature of borderline personality disorder is viewing people as all very good or very bad, and this results in stormy relationships that are very hot and cold. So a person with borderline personality disorder will tell you one day, my boyfriend is the greatest guy in the world, and then they'll tell you a week later, my boyfriend is the devil. There's nothing in between, no gray area. They're always operating in the extremes. Borderline patients also often have a fear of abandonment, and they will accuse others of abandoning them. This is along the lines with the all people are very bad. When they're telling you other people are very bad, one of the things they will often say is, that person didn't stick up for me, or that person abandoned me. Patients with borderline personality disorder often display impulsivity, so they will have a tendency to go on spending sprees or have sex with strangers or engage in reckless driving. And some of this behavior is reminiscent of a manic episode, but in patients with borderline, none of the other elements of mania are present. So these patients aren't up all night with lack of sleep. They don't have pressured speech and psychomotor agitation. So don't confuse the impulsivity of borderline with a manic episode. Borderline patients also self-mutilate sometimes, things like cutting or burning, and they frequently engage in suicide gestures or attempts. And this relates to their fear of abandonment. They will often say, you don't care about me, so I'll kill myself. And that will lead to either self-mutilation or a suicide gesture or suicide attempt. Splitting is a major defense mechanism that is employed by patients with borderline personality disorder. Splitting refers to black and white thinking, so-called always never thinking. So patients with borderline personality disorder can't hold opposing views. In the case of their physician, this means their physician may be great or terrible, but can't be anywhere in between. And just like I said before, these patients often view everything as very good or very bad. So all people, things, and events are either wonderful or horrible. And this is called splitting, classic behavioral pattern in patients who have borderline personality disorder. Super high yield for your boards to know about dialectical behavioral therapy. This is a form of cognitive behavioral psychotherapy, and it was initially designed to treat patients who have chronic suicidality and multiple suicide attempts. It's been evaluated in clinical studies, and it has become the gold standard for treatment of borderline personality disorder. Dialectical behavior therapy involves weekly therapy for 1 to 2 years, where patients practice mindfulness, distress toleration, and emotional regulation, and it's very effective, and you want to know that this is the gold standard for borderline personality disorder. Histrionic personality disorder is another cluster B disorder. Patients who are histrionic want to be the center of attention, so they do things like talk loudly, tell wild stories, use hand gestures when they speak. Another classic behavior of these patients is inappropriate sexually provocative behavior, so things like wearing provocative clothing or touching others frequently as they talk to them. And then because these patients like to be the center of attention, they're very concerned with their physical appearance. So they will wear exotic outfits, shoes, and hats. Women will wear lots of makeup. And these are all things they're doing to try and draw attention to themselves. And the last cluster B disorder is narcissistic personality disorder. These patients are defined by an inflated sense of self. So they brag constantly and they think everything that they do is great. In addition, they have a lack of empathy for others, and that's because they view others as competitors. So they tend to think of them as lesser people because the most important person in their lives is themselves. These patients want to be told that they are great, they love to be told that they are great, and they will react strongly to criticism with an overreaction, usually that involves anger or rage. They don't like to hear anything negative about themselves. We'll finish with the cluster C disorders, and the first one is avoidant personality disorder. And as the name implies, this is a person who avoids social interactions. They are said to be socially inhibited. They behave this way because they feel inadequate and they're afraid that people won't like them. They're also afraid that they will be embarrassed in the company of others. And so as you can imagine, these thought patterns lead them to struggle with intimate relationships, and they will have thoughts like maybe he or she doesn't like me, and therefore they don't engage in close relationships. And make sure you understand the difference between avoidant and schizoid personality disorder. A patient with avoidant personality disorder wants to socialize but is unable to because of feelings of inadequacy and fear of embarrassment. In contrast, as I mentioned before, patients who have schizoid personality disorder prefer to be alone and generally behave in an aloof manner. Patients with dependent personality disorder, as the name implies, are dependent on others. These patients tend to be clingy and have low self-confidence so that they struggle to care for themselves, and as a result they depend on others excessively. Patients with dependent personality disorder are rarely alone and they're always in a relationship. They have lots of trouble making decisions on their own. They want someone to tell them what to do, and they have lots of trouble expressing an opinion. And as you can imagine, because these patients are clingy and they have low self-confidence, it's very easy for them to become involved in abusive relationships, a common occurrence in patients with dependent personality disorder. Obsessive-compulsive personality disorder is defined by preoccupation with order and control. These patients love to-do lists and they always need a plan. And because they're so preoccupied with order and control, they become inflexible at work and in their relationships, and this is what leads to the problems of this personality disorder. And it's very important to understand the distinction between obsessive-compulsive personality disorder and obsessive-compulsive disorder. In obsessive-compulsive personality disorder, the behaviors help to achieve goals, and this is different than in OCD. To understand this better, we have to define some terms. So the ego is the part of your consciousness that mediates the id, which is your desire, and the superego, which are the rules of society. So the ego reconciles the id and the superego and comes up with a plan for how you're going to achieve the things you want to achieve in your life. Behaviors are said to be ego-syntonic if they achieve the goals of the ego. And so ego-syntonic obsessions or compulsions are used to achieve goals. And this is what you see in obsessive-compulsive personality disorder. These patients are very organized and they have checklists and they use those things to achieve the goals they want to achieve in their life. They're so rigid that they have trouble interacting with others, and that's why it's a personality disorder, but nevertheless the obsessions and compulsions help them to get things done. In contrast, ego-dystonic behaviors conflict with the goals of the ego, and obsessions and compulsions that are ego-dystonic are barriers to achieving the goals the patient wants to achieve, and this is what happens in obsessive-compulsive disorder. So a patient with OCD may want to leave the house, but they cannot do so because they have an obsession to keep checking the doorknob and make sure that it's locked. That obsession is a barrier to them getting done what they want to get done, and that's called ego-dystonic. And so it's very important to understand that the difference between obsessive-compulsive personality disorder and OCD is that in the personality disorder, the obsessions and compulsions are ego-syntonic, and in OCD, they are ego-dystonic. And that concludes our module on personality disorders.